going to share with you our experience from the REACH pregnancy program. And Sue was talking before about how we do research because we want to improve quality of health and service experience. And that's very much kind of captures the aims of the REACH pregnancy program. Um, we it wasn't part of our original aim to publish something methodological on how to recruit underrepresented groups in maternity research, but our experience was quite interesting, and so we thought it would be useful to share it with people and to publish it. Okay, so next slide, please. Okay, so the overall aim of the program was to improve access to good quality maternity care and, really beginning to address the kind of inequalities that Sue had mentioned. Next slide, please. I'm going to come on to how we did the program, the kind of shape of things in a moment, but just jumping ahead slightly for a moment, I'm going to talk about the Pregnancy Circles trial. So this is a trial which is not looking at so much at a clinical intervention as a model of care, a whole approach to how to provide antenatal care. And this is something that came out of the community-based co-design work that we'd undertaken before the trial. So I'm going to kind of introduce you to that very briefly in a moment. But first of all, what is this model of care? Some of you might have heard of it. It's been tried a lot in the US and now in a wide range of countries globally. There had been a small pilot study in the UK previously. I can hear an echo. I'm not sure what's happening there. Um, Okay, I'll carry on speaking. I've got a little bit of echo there. And it had been piloted at King's previously and had not been continued. And really out of our co-design work came the idea that this model of care might be useful to address inequalities of access and improve people's experience of care at the very least. So next slide, please. Okay, so this slide just shows you a bit of a very quick overview of the shape of the research. One of the issues I think that forms a challenge rather than a barrier for really good inclusion in research is time, not just budgets, but time. Research projects often have to be done quite quickly. We had the privilege of having quite a long time window for this study. I mean, actually, COVID added 2.5 years to it, but it was intended to be a 5-year program with some previous exploratory work. So you can see there that we started with really kind of community-based co-design. Out of that, the idea for a couple of interventions, including the pregnancy circles, emerged. And we then did an initial qualitative feasibility study to see, can this be done in the NHS? It's not been, not been trialed so much before, and how can it be done? That was then followed up by a pilot trial and then a full trial. And if you can just click on one, if you can move us forward one. Thank you. Okay. So what I'm going to talk about is phase 2. First of all, when we did some test groups to see if it was actually feasible for us to even run a pilot trial. And then if you can click on again. Thank you. And then I'm going to compare that with our experience in the pilot trial. So between the feasibility work and the pilot trial, we put in place some measures to try to improve diversity of inclusion. And that's what I'm going to carry on talking about now for the rest of the presentation. Thank you. Next slide. Okay, so as Sue has alluded to, we know that women from socio-economically disadvantaged or racialized groups tend to have more negative experiences of care. They also have higher rates of non-attendance, and they're experiencing worse maternal and neonatal health outcomes. So these are the kind of problems that we were wanting to address. Now, given that focus in the program, it was very important for us to actually make sure that we had sufficient diversity in our research program. It was intended to address these kind of questions. And we knew from experience that many trials do not include a wide diversity of people for various reasons. So we were kind of mindful of it right from the start, and we learned a certain amount from the feasibility work. Okay, if you can move on, please. Thanks. Okay, so yeah, if you can go to the next slide, thank you. So what did we already know? We know that there's systematic bias amongst researchers themselves. They might be less likely to think about how to include people. They might assume that certain people aren't going to be interested and so on. There are budget issues. I've been involved more peripherally in trials where women who didn't speak English were simply excluded because there wasn't money for interpreting services, for example. Okay, and the next bullet point, please. Lack of familiarity with research, need to actually go out there and kind of make the contact with people and make them feel comfortable and familiar with the research. We were already aware that this could be an issue as well. And next bullet point, please. And then also practical issues. You know, it's easy to assume if you have a more flexible and comfortable life, that it's easy to take part in research, but it's going to be more difficult for some people than others. So we already had ideas about what might be difficult, but we wanted to learn more and make sure that we did as good a job as we could. Okay, next slide, please. Oh, yes, and the last point, I just missed that bullet point there. Lack of trust, I think, is an issue as well, at least for some communities. Is there a kind of feeling of trust that would encourage people to actually take part in research? There has been a history for some communities of exploitative or covert research, which has damaged trust in health research as well. Not so much in the UK, but in the US, that's been a very big issue. So we were aware of that issue as well. So we wanted to kind of learn more about all those kind of things. Next slide, please. Okay, so our feasibility study, we wanted to try out 3 circles, see how it went. This was based in an inner city service that had a very diverse population, both ethnically and socioeconomically. Okay, next bullet point, please. We made sure that our inclusion criteria were very wide. Sorry, I have a bad cold, so I'm a little bit croaky. Um, some of the previous studies of group care in other countries had used quite narrow criteria. And one of the things that we learned in our feasibility work was that women in local communities really wanted the groups to be diverse. They valued the idea of group antenatal care being a way to meet others in their community and get support from other people from a range of backgrounds. So we really were wanting to go for diversity rather than more specialised groups. Okay, next bullet, please. We knew that we would need to fund interpreters in the circles themselves. So for us, there was a kind of double level to everything. We needed to make sure we paid attention to the recruitment, but also it then had to flow through to the model of care itself. Next bullet point, please. The women were offered a £10 voucher for taking part in surveys or interviews, really as a compensation for their time, but we didn't think that that was going to be, the most important or the only issue. There were other issues that we wanted to address. Next bullet point, please. Okay, and to see how we were doing, we measured ethnicity, the level of English proficiency of the participants, and that of course includes all the people who were approached and their educational level, so that we could track how well it was going in terms of recruitment, as well as what was affecting that recruitment, both kind of in research terms and in terms of whether this model of care was going to work for a wide range of people. Next slide, please. Okay, so how did it go? We had a good representation across different ethnic groups. That worked well. That was a relief because it was in a very ethnically diverse area, so it should have been. Okay, next bullet point. So we recruited 24 women, 63% of them were born outside the UK. So that is, I think it's a much better statistic than many studies. And we had a good range of ethnicities. And for this kind of thing, also, I think a pretty standard rate of agreement to take part. So that all looked very encouraging. Okay, next bullet point, please. There's the but. However, when we looked at educational level, we found that the majority of our participants were highly educated, so we weren't getting quite the diversity that we had initially seen. Okay, next bullet point, please. Okay, and also in terms of language diversity, although many of the women were not UK born, all of them said that they spoke English well or very well. And that's in a situation where we had thought in advance about provision of interpreters for the model of care as well. Okay, so we knew that there were areas where we were doing okay and areas where we needed to improve. So we wanted to put in place some measures to improve that. Next slide, please. Thank you. So for the pilot trial, we wanted to increase, in order to test the feasibility of a larger trial, we wanted to recruit around 72 women. Obviously, that's randomization across 2 groups, running 3 circles. Okay, next bullet point, please. Sorry, this is a little bit slower because I can't control the movement myself. So we had 3 inner city maternity services. And one of the great assets for the pilot trial was the fact that these services had bilingual health advocates. So these are people who are more than just an interpreter. They come from the local community. They act more as cultural mediators as well as interpreters, and they're actually embedded within the service. And one of the things that was very interesting from my perspective when we approached the service about being involved in the trial and with this model of care was that they really welcomed the opportunity to be actively involved, and they liked the idea of continuity with the group care schedules because they have the challenging situation often in maternity of being called in on the spot to do this, whereas this model was actually giving them the opportunity to work with a group of women, get to know them, and kind of progress through. You know, they had all those continuity benefits as well. So they were very enthusiastic about it. We did have to fund the additional time for the interpreting for recruitment and for the bilingual health advocates. And I think there's a lesson there. I'm sure I'm going to say it again at the end, but very often when budgeting takes place for studies, the budgeting is quite tight and people don't necessarily allow a lot for these kind of levels of activities to make sure that the study is really inclusive. So we needed it to be there in the service, but we also needed it for the recruitment, and it wasn't routinely there. So we actually had to fund that as an additional cost rather than something that was just funded through the Clinical Research Network, through the NIHR portfolio. We had quite a range of languages in our own centre, which was very useful, but you can't rely on that. But we made use of bilingual research staff as much as we could, particularly for interviewing. And another thing that we'd realised in terms of recruitment of women, a wider range of women, was that we might have been missing women who booked a little bit later. So we widened our recruitment period and had another recruitment session at the ultrasound scan at 20 weeks. And that helped to bring in women who might have been missed out because of later booking otherwise. Okay, next bullet point, please. Okay, and then I suppose there were 2 layers to the training with the midwives. On the one hand, we had to provide training for the midwives who were going to facilitate the circles. This was very new to them. And also we were asking them to run groups that were quite diverse in terms of first baby, subsequent babies, different levels of risk, different languages potentially, no more than 2, but different languages nonetheless, and people from a diversity of backgrounds. So the midwives needed to kind of skill themselves up there as well. But also we needed to put some work in to the research midwives who were doing the recruitment, because we found that in practice they hadn't had much opportunity to develop expertise in recruiting a wide diversity of people. Okay, next bullet point, please. We also were aware from the feasibility work that ideally we should be able to have creches for the intervention. Now, that's a particular thing, I think, to do with our trial, because we were looking at group care, which is a much longer session. And I'll come on to the data about that in a moment. Okay, next slide, please. Okay, so again, this time we looked at parity, ethnicity, educational level, and English proficiency. And we asked those who declined, very kind of making it clear that this is about us learning, not you having to justify why you didn't want to take part, but we can learn from you if you don't mind spending 5 minutes having a quick chat about this. So an anonymous survey, which they could fill themselves or could be filled for them to help us to understand the reasons for declining, so we could learn more to feed into the full trial. Okay, next slide, please. Okay, so what did we end up with? This is just a quick overview, and you can see there that these measures did actually help to improve things. So as I said, with the feasibility study, we actually had quite good diversity in terms of ethnicity, but not in terms of education and not in terms of language. Parity was pretty okay in both cases. So we saw an improvement there in terms of English, and you know, quite likely that was down to having had the interpreting at the recruitment, and in terms of educational level as well. So it did show that the additional measures that we put in did seem to make a difference. So this was in the same area. Okay, next slide, please. Oh, that's just highlighting what I've already said. Okay, and then if we just do a comparison there of those who participated and those who declined, we were able to use these very quick surveys to get a sense of whether there was any pattern to people saying yes or saying no. And you can see there that there was still more likely to decline if you didn't speak fluent English, and a little bit more likely to decline if you had babies before. And I'll say a little bit more about that in a moment. But certainly an improvement in terms of language on the feasibility work. Next slide, please. Okay, so this wheel shows the kind of reasons for declining. This was very informative for us. So we learned that a lot of the problems were actually practical ones to do with the model of care and how we needed to make the model of care more accessible. And it was interesting that it didn't match very well with what some of the more senior people, not the frontline midwives, but some of the more senior people had said to us when we did our initial feasibility interviews. Oh, women from certain backgrounds are unlikely to want group care. So there was a tendency to possibly slightly protective steering going on there, thinking that certain people in your community won't be interested in something rather than really going and finding out. And actually, it just was not very common for women to decline on the basis that they didn't like the idea of a group and privacy and so on. This was relatively uncommon, just a few. It was more often childcare issues, work issues, because of the 2-hour sessions. Women who were in more insecure occupations were worried about the reality of being able to get time off work. And then also the midwives had great difficulty in accessing community venues. Many had been closed, in a period of austerity. And also, despite, what might come out tomorrow in the NHS 10-year plan, a lot of divisions between health and social care, cross-charging and so on. So the midwives struggled to get accessible community venues for the pilot trial. So, okay, next slide, please. What did we find? I'm just going to try and sum up. So the women who had a lower educational level were more likely to decline because of practical issues, caring for young children and lack of childcare, actually more than work issues. Next bullet point, please. And then the women from a white background were more likely to cite insecure work and difficulty getting time off work as a reason to decline. And that might reflect the local kind of profile of the local community in that area as well. So it's not necessarily totally transferable to everywhere. Next bullet point, please. This is an area with a very high Bangladeshi population, and a lot of the women cited caring responsibilities as a key reason for declining. So that was important for our area. It might be a little bit different in some other areas. Next bullet point, please. Only one woman declined citing language problems, and it did seem to be more practical issues that were driving that. But this, I think, is because we done a lot of work to put proper language support in place. And as I was saying before, that is not as routine and common in trials as you might hope and think it is. Okay, next point, please. Key points about how we could have improved in recruitment further. Clearly providing provision for childcare for a study like this, which wasn't, a drug trial, it was more a time commitment for the women, would have made the most difference, we think. Better access for the midwives, better integration of midwives with community services would have helped enormously. Challenging the women's assumptions about this model of care. It was interesting that when we did our PPI work initially, the women who'd had a baby before tended to say, what you don't know when you haven't had a baby before is that you may spend 2 hours because you wait ages in the clinic and then you have a really quick visit. So, take this into account. But if you're having your first baby, that may be less clear as well. Okay, and the next slide. So, as I've mentioned, we can't automatically transfer these findings to other areas because you might have a different population profile in the area where you were doing a trial. One of the things that just didn't come up for us, for example, was lack of trust in health research. And I know from experience working in other trials in this area that the level of trust in health professionals and health research in the kind of North and East London community where we were doing this work is high, but it could be a big issue in other areas. So that's not something that our study touched on, but may be important. I think there's a key lesson there about how clinical research networks are actually designed and resourced, because the default model, I think, this is me inferring from our experience in this trial and other trials, the default model is of a much simpler interventional trial, usually something modeled more like a specific treatment, a drug treatment, where recruitment can be very quick. This is quite a complex model of care. The research midwives needed to take time to explain it. And then if you need interpreting as well, you need to allow extra time. So inclusion takes time, and that really needs to be built into the system. So I think, we have a lot of good intentions and a long way to go. The other thing that we did experience was unconscious bias. I think it wasn't a big issue later on in our experience because we did a lot of work with the research midwives to try to kind of get across the importance of diversity in these groups, that this was really important for our study focus. And please don't try to decide who's relevant to approach or not, but I think it's something that they get used to doing. So there's always the issue of trying to counter gatekeeping that's well intended but may actually inadvertently exclude some people. I've mentioned also the impact of austerity in terms of closure and withdrawal of community services. That made this kind of trial more difficult, not least the fact that by the time we started the full trial, the bilingual health advocacy service had been withdrawn from the service, and the services were tending to rely on telephone interpreting, which isn't the same. And obviously, we're talking about a complex intervention here, highly complex intervention. That's pretty typical for midwifery. So that lesson about how much time and resource needs to be built in, I think, is something that we need to keep feeding back to clinical research networks and funders and so on. Okay, and I think I've got the last slide now. Just a few recommendations from our experience. So try and make sure that you write these things into your design. Think about how the service might shape it. Think about language and how you're going to cater for that. Think about caring responsibilities, particularly when you're involving mothers of young children in research, and also the impact of insecure working conditions on people in more disadvantaged population groups. Okay, and the importance of engagement. We had the privilege of having a lot of time to do engagement and talk to people. Wherever possible, try to build it in to what you're doing. Take your time to build a project. It's really, really worth it to do that initial engagement by whatever means you can. And that's it. Thank you.